Hello, everyone. Welcome to the National Fellow Online Lecture Series. Our topic today is Jeopardy-Style Pediatric MSK Cases. My name is Dana Sheng. I'm a sports medicine physician at Dignity Health, and I will be your moderator today. The lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. Before we get into tonight's talk, I wanted to remind everyone of the lecture in 2 weeks on sports neurology with Dr. Morgan Heinzelman-Weisbaum. The goal of the lecture series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced AMSSM members and at times embedded guest speakers in a variety of formats. And finally, this is also meant to assist in CAQ exam preparation. So some reminders: make sure to mute your microphone, turn off your video. You can submit questions at any time through the chat function. And at the end of the talk, I, as the moderator, will ask questions during Q&A based on the questions you submit. And after the program, we would love your feedback. There are a couple ways to do this. First, a web link can be found by going to amsssm.org, click the Education tab, and then select Fellow Online Lecture Series. The link is near the top of the page, as seen in the screenshot. Second way is by scanning the QR code, and it should take you directly to the form to fill out. When filling out the form, we ask you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker today, Dr. Jonathan Samet. Dr. Samet is primarily based at Ann and Robert H. Lurie Children's Hospital of Chicago, where he serves as the division head of body imaging and the section head of pediatric musculoskeletal radiology. He's also an associate professor of radiology and orthopedic surgery at Northwestern and works in the adult MSK radiology section there. He trained in diagnostic radiology at Northwestern, followed by subspecialization in MSK radiology at Johns Hopkins, and is board certified in diagnostic radiology and pediatric radiology. He has a particular interest in pediatric MSK imaging and leads regular sports medicine radiology conferences at Lurie Children's. And with that, welcome, Dr. Samet. Thank you so much for being here.
Thank you so much, Dr. Sheng. Really excited to be here and give the radiology perspective. And I've worked with sports medicine fellows over the years, many, and I really enjoy working with you guys and teaching you what we do in radiology. So let me now go to my talk. And apologies, this is supposed to have fun sound to this, but couldn't get it to work. So you're going to have to imagine what this sound was like. Okay. So we're going to play Jeopardy today, and we are going to have a number of different categories for you. This is a sports medicine talk, but as you guys know, you're going to be faced with many things that are mimics for sports medicine, and you need to know when to say, hey, this should really be kind of referred to someone else, and make sure that we don't miss anything. So there are the categories. And I do see that there are a lot of people on this message. So if you would like to chime in, you're more than welcome to. We can make it a little bit interactive. I am going to also keep the little chat box open for myself if you don't want to unmute, but you can give a little comment, and don't be worried. I will help you through the cases, but I think it's good to try to just guess on what you would say. So if someone wants to put in the chat what category they would like to start with, and we'll go from there. I see in here, aha, trauma 100, excellent. So this is a patient who had a football injury, and we're showing you a coronal T2 weighted sequence of the left knee. What do we see here? Feel free to type in the chat, and then I will explain the findings. So what you notice is that on T2 weighted images, there is a lot of this bright signal. So this is edema or fluid on MRI. That is the mainstay of what we use to evaluate trauma, and to try to figure out where we should look. So I see someone said periosteal edema. There is edema along the bone. It's more just sort of soft tissue edema, though. I am showing you, and it's always hard to show MRI on just a still image, but I have scrolled through to the case right to the level of the medial collateral ligament. So check out this ligament right here and think to yourself, what should it look like? And what is going on here? What's wrong with this ligament here? And one rule that I have is if I see a little black squiggly line, then I get concerned that something has ruptured or injured. And what you're seeing here is that instead of seeing a nice straight line to the MCL, you're seeing the femoral attachment, and then you're kind of seeing a little squiggly line, and you can't really follow it. So this was an MCL tear. And really on all sequences, ligaments and tendons really should be hypo-intense, very, very dark in signal, should be straight. You shouldn't really have any squiggly line there. Awesome. All right. Next category, next dollar amount. Anyone there? Shout out a little number there. Ped Paris, 200. Awesome. Okay, so this patient came to your clinic and they said they sprained their ankle a couple weeks before, but mom says that maybe it's kind of gotten red and may have had a little fever. So we're thinking something else could be going on. And so I'd like you guys to take a look at this image here and see if there could be something we're missing here, meaning might it not be a sports injury? And so what I'm showing you here are two T2-weighted sequences. These do not have contrast. This is a coronal, and it's scrolled to the level of the fibula here. And this being an axial T2 fat set as well. And if you want to try to attempt to describe something, don't be embarrassed. I will not laugh too much in how you describe, just joking. And we will kind of show you guys how to kind of describe some of these findings. But what we are seeing here is that there is kind of this abnormal lifting of the periosteum. So this black line here. Normally we don't see this lifted off the bone, right? It's just kind of blends in with the black cortex. But we are seeing this periosteum lifted off the bone circumferentially with this T2 hyperintense fluid underneath it. So we essentially have subperiosteal fluid. Someone wrote, what about the lateral tibia? The lateral tibia is shown over here. I think it looks okay. And you might be referring to this area over here. I think it's just sort of the volume averaging of this area, but focus on the fibula. And we're seeing here in the marrow of the fibula, it's kind of heterogeneous high signal, a lot of surrounding soft tissue swelling. So you as sports medicine person are going to be thinking, is this really a sports injury or is this something else? And given the history of the kind of the swelling, what are we thinking? So excellent. I see someone putting there osteomyelitis. Perfect. That's what I wanted you to get at. And it's osteomyelitis, but also could you name this subperiosteal fluid thing? What is that? A complication of osteomyelitis? What is that called there that will typically need to be drained? So basically it's subperiosteal abscess. So it's just osteomyelitis with a little abscess that's lifting off the periosteum. Excellent. And in traumatic injury, we don't often see this. We can sometimes see subperiosteal hemorrhage. A lot of the fractures that we see in peds, we are using X-ray to diagnose it. Occasionally, when you get an MRI, you might see like a subperiosteal fluid collection, but usually it's in infection cases. So this was just showing you a pitfall. of his subperiosteal abscess. Okay, excellent. Moving on. Let's pick another category here. Trauma 200, perfect. All right, so it's not exactly trauma, but basically this patient is 11 years old, comes to your clinic, and is very active in sports, plays basketball multiple times a week, and just has noted this nagging knee pain. X-ray didn't really show much, and we have an MRI. So what are we showing here? This is a T1 sequence. You can see the fatty marrow, the fat in the popliteal fossa, subcutaneous tissues, and these are two T2 weighted sequences. You have a coronal and you have a sagittal. So subtle finding, but something that you, I'm sure, know of. What do we call this, and what do we need to do? What does the radiologist need to put in a report for you guys to kind of tell you, do we need to treat this correctly? Is that the medial aspect of the lateral femoral condyle on the sagittal? This is the this is actually the medial femoral condyle, and it corresponds to this here. So fibula being lateral, so this is the lateral aspect of the medial femoral condyle. So this being, looks like an OCD, excellent, very, very good, possibly unstable with collapse. So it actually is a stable lesion, but let's talk about that briefly. So medial femoral condyle near the notch is the most common predilection site for OCD in the knee. And when I'm reading out a report, I do like an outside-in approach, and I describe a lot of the findings. And then I try to make some qualitative assessment on if it's unstable or not. As you know, MRI is not perfect for this. I think there's been some newer articles that have come out that have helped talk about certain features, but we can't just use the adult criteria. It doesn't work as well in peds. So the outside-in approach, what is it? First, I look at the overlying articular cartilage. And here you see a nice smooth grayish line over here as well. So there's no articular cartilage fissure or defect. Then next, I go deeper and I look at the subchondral bone plate, which is this next black line here. And we're looking for areas of cracks or disruption. That's a sign of instability. We don't see that either. Then we go deeper and we see if I talk about deep margin features. So we'll talk about, is there a fluid cleft or are there cysts forming? So fluid cleft, it's a little bit debatable of what that means, but usually a well-formed fluid cleft would be a white line bounded by two black lines. You might have heard the Oreo cookie sign. This just has a little strip of edema, but not necessarily a well-formed fluid cleft. And then I also look for cysts, so rounded T2 bright foci. The more cysts and the larger the cysts that you see, that will be associated with poor healing potential in the literature. So in this case, we don't really have any of the red flag findings for instability. And this was arthroscopically proven to be a stable lesion. So this is an OCD, and this happens to be a stable lesion. And if there are questions as we go, please fill up the chat. I have it open, so I'll be looking and I can answer them as we go. Next case. Okay, sports for 300. So this patient had a skiing injury. We are showing you a coronal and a sagittal T2 fat suppressed sequence. Notice how most of the T2 weighted sequences I'm showing you have fat suppression. The reason we do that is because we want to minus out all the bright signal from fat to really focus on soft tissue swelling and edema, and that's how we're going to find most of our findings. So I'm showing you a slice directly through the intercondylar notch, and I'm not trying to trick you here. So we're showing you something that should be here, if you can see my mouse cursor. And then on the coronal image, we're seeing sort of an absence of something in this area here. So what am I showing here on MRI? And there's also a joint effusion. Correct. We are showing you an ACL tear. We're not seeing the nice linear ACL fibers here. We're seeing an empty notch, and we're seeing a joint effusion. Now, I will tell you, as you're interpreting MRI and looking at MRI, ACL can be tricky. It seems like something that shouldn't be that tricky, but it actually can be. One thing that I will say is the PCL and the ACL have a different appearance, and you should expect that. The PCL is more of a compact ligament. It's a darker on MRI. The ACL can and often does have multiple linear strands within it. And so I think of it as sort of like a broom, like you're sweeping. It's expected to see multiple fibers through it. And within those spaces between the fibers, often there's a little bit of T2 signal. And so when I work with my trainees, sometimes it's very tempting for people to call low-grade ACL sprains or grade 1 ACL sprains. I personally try to not call grade 1 ACL sprains unless it's really, really prominent, just because it's very hard to tell if it's just sort of the normal striation that you see in the ACL. So for me, I usually just stick to, is it torn or is it not torn? And I think that's more of a kind of a reliable way to report. All right, excellent. Okay, bone lesions. This is it is a 500 level. So I'm just going to go over this one because this might be slightly out of the scope of this talk, but it's teaching you something very interesting about MRI signal. And I think it's important for you guys to realize what is something that is bright on T1. So this is actually an adult patient, but showing something very interesting. So you see something that is basically pet avid in the sternum. So someone comes to you with sternal pain, trying to figure it out. CT portion of the PET, we don't really see much of a lesion. Then you look at the T1 and you say, that's weird. There's nothing there. I don't see anything. It's fatty marrow in the sternum. But then we do a T1 with fat suppression, and the signal still stays bright. So something that I wanted to keep with you guys that I always teach the residents is, what is bright on T1? And I want you to try to name a couple of things that are bright on T1. And that will help you when you're interpreting MRIs. So you probably all can answer this one, right? So this tissue in the subcutaneous space is bright on T1, right? So we know that fat is bright on T1. But also blood products are bright on T1. So if you have a big hemorrhage, you might see some bright signal on the T1, and that's actually important to realize. This case is showing more of an obscure thing that's bright on T1, and that would be melanin. And melanin within a melanoma met is T1 bright. And that's why when we did fat suppression, it did not go dark. So we know this isn't fat, but it stayed bright and it was PET avid, and this was a melanoma metastasis. But the point is that things that are intrinsically bright on T1, you're thinking fat, hemorrhage, proteinaceous material, and that's what I wanted you guys to remember. Bone lesion 100. Awesome. Okay. So this actually came through our ortho clinic. So even though this is a bone lesion, I'm showing this as a real case. This patient had hip pain, and they did an MRI. An orthopedic surgeon called me and was asking, what do I think is going on? So you want to look at this, and I have a CT scan. This is a CT scan as well. And try to figure out, first of all, where is the lesion? Like what is going on here? This is clearly not, you open this up, this is not your typical sports case, right? But you guys are going to see these patients. When you look at the T1, you look for symmetry, and it's very helpful. So we all know that you have the epiphysis, the metaphysis, and the diaphysis. But remember that the greater trochanter, of course, is an apophysis with an A. And apophyses are epiphyseal equivalent. And it's, if you remember one differential for bone lesion, whenever you have an epiphyseal lesion or an epiphyseal equivalent lesion, You want to think of a particular diagnosis in the differential 1, 2, and 3. Does anyone know what that is? Differential for an epiphyseal bone lesion. And that's what I'm showing you here is the lesion is in the apophysis, because you see here we have replacement of the fatty marrow. And then on the CAT scan, it's showing you another hint. The lesion is in the greater trochanter, but there's these little tiny dots of calcification. So this is a cartilage-based lesion, a chondroid lesion. So there's a lesion in peds that we really want to remember for epiphysis and epiphyseal equivalence. Giant cell is a good thought. We don't see that in pediatrics. Usually it's 20 years old and over, and it wouldn't have a chondroid calcification. It's a very good thought, though. It has chondroid in the name, and it is chondroblastoma, which is a benign but locally aggressive lesion. And it is basically seen in epiphysis and in epiphyseal equivalence. We just had a case last a few weeks of a patient with a lesion in a carpal bone, ended up being chondroblastoma. It came through sports med, and there was a lesion in the hamate. And if you use your differential diagnosis that you have something in an epiphyseal equivalent, you can come to chondroblastoma. All right, next one. Soft tissue for 100, someone wrote. Okay, so this is an axial and a coronal T2 weighted sequence. We did not give contrast. And this is a pediatric patient, of course, that came to your clinic. They said they bumped their wrist. There might have been a trauma. However, you notice that there's actually this bluish discoloration right over the wrist, and it doesn't really look like a bruise. So what do you need to think about? And I think this is true, and I'm sure you guys know this better than me, but if patients have musculoskeletal complaints, they might first just go to a sports medicine or orthopedic person, but in reality, it could be something else. So you're looking at this and you're saying, this is not quite a bruise. And the bluish discoloration is key. And the patient has said that it's kind of been there for a few years and it's kind of gotten bigger over the years. Excellent. Venous malformation. Perfect. So that's what this is. This is the venous malformation. And I'm showing you some very characteristic features. So we see a lesion, but notice that the margin of the lesion has these like little finger-like projections, lobulations. This little black circle or ovoid thing is a phlebolith. That's what it looks like on MRI. So this was a venous malformation. And so it's just good to kind of keep in the back of your mind that not every discoloration is going to be a traumatic thing. And so we often see venous malformations, and sometimes we see them present after they have bled for the first time. So take a good history and see, you know, has it been there for a few years? Venous malformations will typically be present for many years and will grow with the patient. And so this was a venous malformation. Very good. Next category. Okay, 200. Awesome. Okay. This patient is 5 years old, and they came to your clinic with a posterior knee mass. They ordered this test. You guys didn't, because you knew that you didn't need this full-on MRI. However, this test was ordered on the outside, and we're showing you an axial T2 weighted sequence and then an axial T1 post-contrast sequence of the knee. What are we seeing here? Posterior knee mass. And I'll describe it for you. Oh, excellent. Someone put Baker's cyst. Perfect. Now, this is a Baker's cyst. So a cyst on MRI, any cyst, should be T2 hyperintense. And if you give contrast, it will have no central enhancement, but it will have rim enhancement. And what distinguishes this from, for example, any other kind of ganglion cyst, in this case, we're seeing it in the classic location, posterior medial knee. And what you're seeing here are these two tendons, and it has to go through those little tendons, and it has a comma shape because of that. These two tendons that it typically goes through are the medial head of the gastrocnemius and the semimembranosus. So those are both medial sided things. I show this and I was teasing a bit, but making the teaching point that if you are suspecting a Baker's cyst, really you should be ordering an ultrasound. An ultrasound would be the non-invasive way to image this. We can diagnose Baker's cyst with ultrasound. You may need an MRI if you're concerned for other associated internal derangement, but as a start, you could do an ultrasound and you might just be able to clinch the diagnosis. So I usually try, I love ultrasound and I don't like to put kids under general anesthesia and give contrast if we don't need to. So that's my little plug for non-invasive imaging. Next case. Aha, sports for 100. All right. You might need to zoom in on this just to make sure you can see it. This is a patient who twisted their ankle pretty bad. They came to the ED and we are seeing an AP view of the ankle. Yes, someone said Salter 3, excellent. Now, what we are seeing is a little bit of widening of the lateral growth plate and this oblique linear lucency. It's very hard, and this is something you can easily miss depending on the exact orientation of the fracture cleft related to our standard imaging planes. So this is a Salter-Harris 3 fracture. Given that it is in the anterolateral corner, is there a name to this kind of fracture that you guys know of? Juvenile to low, excellent. Now, I will have a companion case, but one thing I usually teach residents is that a juvenile to low can look similar to a triplane fracture on an AP. There is a distinguishing feature on the lateral that will help clinch or push you away from the diagnosis of triplane, and that would be a metaphyseal component. So we always want to just double check on the lateral to make sure we don't have a metaphyseal component. That's a hint for the next case. All right, next category here. Okay, Ped Pori 100. All right, patient comes to your clinic. You're in the urgent care. You are seeing this ankle film. The patient says they may have twisted their ankle, may have not, we don't know. But they are just been having worse and worse pain. And it's kind of red, a little swollen, and you are concerned about something. What are some of the findings we see here on this ankle film? And it is hard in the soft tissues in peds, but so there might be some soft tissue swelling. Yes, there's soft tissue swelling. Good. What's going on with the tibia here? What is something that shouldn't be there? Yes, there is some bone destruction, right? We have this abnormal lucency. We have a lytic lesion. We have some periosteal reaction, right? So we're not sure what this is yet. We do know that the lesion is in a particular part of the long bone, right? So it's in the metaphysis and it's right next to the growth plate. And I gave you the hint that this patient had some redness. I'll tell you that they also might have had a fever and the white count is pending. And osteomyelitis, that is excellent. So what is a complication of osteomyelitis that can occur if you have an untreated osteo? What might have occurred right here, which loves to occur in the metaphysis? Osteonecrosis you can have as a complication of osteomyelitis. That's true. I'm more getting at the infection kind of festering and producing something breaking down the bone. S, abscess, excellent. So I'm showing you an intraosseous abscess. You have probably heard Brody's abscess, and this is a complication of osteomyelitis, so subacute osteomyelitis. You will occasionally see this, and we've seen it a number of times present. You can see it on X-ray. And if you see something in the metaphysis, that's where osteomyelitis loves to go. And so always think about intraosseous abscess, and you would want to order an MRI for that. Next case. Bone marrow. Excellent. My favorite. Aha. Tricky one. You are doing an MRI here. And it is a patient that I don't know why they got this. Let's just say they were ruling out hip dysplasia. You would never do an MRI for this. But someone called you or you looked at it and wondering about the bone marrow. Is that normal or abnormal? What is going on with the bone marrow? And this is very tricky, right? Because how do we even assess the bone marrow? There's the different parts of the bone we have to remember, and they will undergo fatty changes as the patient ages. So we have the epiphysis, this little ossification center. We have the metaphysis, the diaphysis. So this case is showing you normal red marrow. And the teaching point here, and you're not going to become a bone marrow expert just after this talk, but remember that you're born with basically 100% cellular marrow. And then as we age, it'll become fattier and fattier and fattier, sorry to say, in a predictable pattern. And so in the long bones, the epiphyses and the diaphyses will become fatty first, and you'll start seeing residual red marrow in the metaphysis. But when they're very, very young, you still can see everything dark here. So, but this is when you would want to call your radiologist and just kind of double check. Marrow 200, you got it. This patient had neck pain. You're seeing this patient who has neck pain. They got an MRI. You look at this. This is like really weird looking. Why is this marrow very bright on T1? And we said that bright on T1 was fat. And then the bottom part is dark on T1. So what is going on here? And the history, which I will tell you now, is that the patient had a history of some kind of malignancy in the head and neck, and they had a treatment done to this area. Could you name the treatment that they might have had that would cause all of the marrow to turn fatty? And this is a very typical appearance of a radiation port. Excellent, radiation. And I just gave it away as I was saying it. But you typed it first, so good job. This is a very good appearance of radiation change in the marrow. And you are going to see that, and you are going to see this kind of stark kind of cutoff here between the red marrow and the fatty marrow. So this being just radiation changes. Sports for 200. Okay. This patient twisted their ankle again, and we are seeing something going on. So how do we describe it, and what is it? A lateral and an AP view of the ankle. There could be a little widening here. That's possible. I was showing it for something else. Look for fractures. Okay, so I'm seeing a few different answers here. Let's pass the fibula. I think the fibula is okay. I'm actually trying to show you something in a few different areas here. So this just being the growth plate, someone put Salter 4, excellent. You're seeing a line here from the growth plate to the ankle joint. So that would be a Salter 3 component. However, we also have this, right? So this is a fracture involving the metaphysis, the growth plate, and the epiphysis. So this is a Salter-Harris 4, and this is a triplane fracture. Excellent. So a triplane, right? It's a fracture in 3 different planes. So you have the metaphyseal component, the growth plate, and the epiphysis. And so because it involves the metaphysis and the epiphysis, it's Salter 4. And now that we've shown a triplane and a Tillot, those are basically the 2 fractures you need to know. We just want to make a comment about when to do advanced imaging. So at our institution, when you have a triplanar Tillot, they may often do a CT if they want to assess the articular surface gap, the displacement. And I think that's a very reasonable approach. Extremity CT is a lot less radiation than other parts of the body. And in children's hospitals, we take great care to lower the dose even more. So if you are on the fence about doing an ankle CT, realize that it's very little radiation and you shouldn't feel bad getting one if it's going to affect your management. And so when we do a CT, I'm basically going to be getting a really nice look at this area here and going to try to measure the articular surface gap for you guys. And 2 millimeters is sort of like the magical number, I feel like, where if it's more than 2 millimeter displace, then surgeon might consider doing a fixation, but basically putting a screw through the epiphysis transversely in this area here. If it's less than 2 millimeters, then they can't really make it better, right? So they kind of would just put it in a cast. So that's when you would order a CT to measure the articular surface gap on these cases. And again, if you have questions, please put them in the chat. Happy to try to answer them. Okay, I see sports for 400. This is a grainy film, but just wanted to show this nice case. This is a patient that twisted their knee, and you get a call from the resident, hey, don't worry about it. I just see like a small little chip fracture. You don't need to come in, everything's fine. We don't need to worry about it. What about this fracture is kind of a little concerning here, and I shouldn't have put an arrow to it, but first tell me where the fracture is and what could this signify? What is going on here? So it's the fibular head, exactly. And what kind of because you know about exactly posterolateral corner injury, right? So what attaches here? What do you know anatomically that attaches to the fibular head? Right. So the LCL. So the LCL goes from the femur to the fibula. We also have the biceps femoris tendon attaching here, forming your lateral ligament complex. There's other smaller ligaments. So if you have an avulsion fracture, then you have really a posterolateral corner injury and you've lost your stability here. So we don't want to be kind of lulled into the sense that it's just a little non-displaced fracture. Don't worry about it. We really want to worry about a significant lateral sided injury. Someone put Mason-New fracture. That's a very good thought as well. Possible. Usually, it's usually a little bit lower, and there'd be an ankle injury to go with it. But that's not a bad thought at all. But I'm showing this more for the posterolateral corner injury, just to kind of and it's called the arcuate sign, but to basically remind everyone that if you see that, think in terms of MRI. And I think it's always important to, when you're looking at plain films, to imagine what the MRI would look like and just kind of think what's behind that. And that's more, I guess, of a teaching point for radiologists, is to kind of remember what's behind there on the anatomic thing, not just look at the bones. So next case here. You guys are doing great. Bone lesions 200. Okay, this is a 2-year-old that came to your clinic with a limp. Mom is thinking that there might be some injury on a trampoline. She doesn't know, she can't remember, but you get a set of films and you see a surprise. So you're going to get these cases and you need to have something to say about it. So I'm showing you an X-ray, showing you an MRI, a T2 sagittal, and a T1 image there. Remember, the patient is 2 years old. So what kind of differential can we say? And what do we think is going on? So someone wrote osteosarcoma. Not not a bad thought. You're thinking, could this be a malignant lesion? Typically, osteosarcoma is in the metastasis, and it's going to be a sclerotic lesion, which this is more of a lytic lesion. So Ewing sarcoma will be the one thing you more would be scared about. However, what's with this periosteal reaction? Does this look scary, malignant looking, or is this more kind of smooth and kind of benign looking? So it's kind of an interesting thing, right? The lesion is very prominent, but it actually has a benign periosteal reaction. Excellent. So a couple of things were thrown out. So osteochondroma, remember, is a bony outpouching. So it's a bony outpouching. It's something that extends out of the bone, and it's usually in the metaphysis pointing away from a joint. Enchondroma, not a bad thought. We don't see enchondromas that commonly in peds. This is very big. What if I told you this patient has some weird like rash also? Um, they have some inflammatory markers that are up. And what else? That there's I tell you, they have a some neck pain. You got an X-ray, and there's a vertebra plana in the one of the vertebral bodies. And there's also a calvarial lesion too, a little lytic lesion in the calvarium, and you're like, whoa, wait a minute, there's multiple bone lesions. Someone said chondroblastoma. Remember, that's an epiphyseal lesion. We don't see chondroblastoma in the mid diaphysis, so save that for your epiphyseal lesions. This might be a little bit less common for you guys to see, but this is Langerhans cell histiocytosis, so LCH. So just keep that in your back pocket for kind of punched out lytic lesions and in young kids. Okay, soft tissue for 500. Awesome. Patient came to you with a mass. It's a little higher than you typically would see for a Baker cyst. So you're thinking, is this really a Baker cyst? No, because it's above the popliteal fossa. So you're going to have to get an MRI. And I'm showing you a T1 sequence. So just tell me what signal is this based on what we've talked about, and what does that mean that this lesion is containing? What material is this lesion mostly composed of? So it's a T1 sequence, and it's mostly composed of fat. So you have a child with a fatty lesion, or lipomatous lesion, as we say. What would be a common lesion that you might see in kids that's a fatty lesion? And it is benign, but can be locally aggressive and typically will need to be removed. But it's a really good differential if you have one differential to remember for fatty lesion. You can have lipoma. You can have lipoma. Liposarcoma we don't usually see in kids. Thinking of the one in between those two. It's an entity that is a little bit more than a lipoma, but it's not a cancer. Lipoblastoma. Excellent, excellent. So this is lipoblastoma, and I think it's important to remember that when you are feeling around masses in the knee, you want to remember that you really should only say Baker cyst if it's posterior medial. If you feel a mass and it's not in that area, you really want to do a further workup for something else. We've seen cases over the years of things that can mimic Baker cyst. Obviously, on exam, it might feel different if it's a tumor, but we've seen synovial sarcoma be around the knee, and we don't want to just kind of assume that it's going to be a Baker's cyst. So there's other things just to remember. Excellent. Next case here. Sports for 500. All right, this patient had an injury, and you are suspecting an internal derangement, so you get an MRI. We are seeing a coronal and an axial T2-weighted sequence. And I'm showing you something on the coronal that I have cross-referenced and happen to find on the axial. Now, the axial is not your main sequence for meniscal pathology. However, I always look at it because sometimes you get lucky and the abnormality happens to be right at the exact slice that you're looking at. The hint is we're looking for something in the meniscus, and we're looking for the name of the kind of meniscal thing. So someone wrote discoid meniscus with tear. This is not a discoid meniscus, but I think what you were thinking was this is lateral, so that would be a common lateral meniscal issue. So that's you're on the right track. So this is the lateral meniscus, and there is something wrong with it, but the meniscus is not enlarged. Discoid meniscus is when you have the tissue that goes really far into the notch. This is sort of a normal size meniscus, but there is abnormal signal within it that we're seeing here, sort of vertically oriented. And then on the axial, you see the C-shaped meniscus, and you see a tear cleft that's first going perpendicular to the fibers and then curving as well. So it actually has this curved appearance. So it's a kind of tear that is very interesting. No, it's not a bucket handle tear. So bucket handle tear is when you have a tear and the meniscus flips into the intercondylar notch. This is actually a radial tear that is a parrot beak type radial tear. And so what that means, first of all, to step back, what is a radial tear? A radial tear is a bad tear because it can disrupt the tensile strength of the meniscus. But basically, if you look at the fibers, they're going in this direction, this C shape, this dark tissue. Radial tear means that it goes perpendicular to the longitudinal fibers of the meniscus. So kind of like the radius of a circle. But in this case, instead of it being a pure radial tear, it curves. And so it's a special kind of radial tear where it has radial and longitudinal components. But the point is that it's a radial type of tear. So this is a 3-year-old patient, sorry, that mom said, or dad said, I would keep saying mom said, parents said that they were watching their kid just kind of run around the playground. Just all of a sudden, kid fell down and the knee was locked, and kid could not get up, and then started crying. And after like a few minutes, the knee kind of basically popped back and kid was running around again. And this has happened a couple times over the past few months where it sort of just locks up and then all of a sudden everything's fine again. And so do we see anything on this scan that kind of explains, and going along with that history, what is going on here? We have a coronal T2 sequence. I'm showing you right at sort of the mid part of the knee. And what are we seeing here? And the hint is that I want you to focus on the menisci and think about that history I gave you. Yes. This is a discoid meniscus. So what should a meniscus normally look like? Well, on a coronal, you're going to see a nice triangular shape, right? You have a nice sharp point. You should never have a blunted edge to it. You shouldn't see any lines in the meniscus. When we look at the lateral meniscus, the meniscus is much enlarged, and instead of it being a triangular shape, it's going all the way into the notch. And so this very enlarged meniscus is a discoid meniscus. And as you know, what is the risk of discoid menisci? Is there association with this? What do we have to worry about as sports medicine providers? OCD, I think you're right. More kind of in the post repair, but like what, stepping back more kind of obvious, like what can happen to discoid menisci? What are they more at risk for, is what I was getting at. Like this discoid has not torn yet, but when you're tearing, exactly. So tearing. So when you see a discoid meniscus, they are more at risk for meniscal tear. They're just, the bigger it is, it just has a higher propensity to tear. And so you're going to want to have to counsel the parents that, hey, you have this discoid meniscus and they're more likely to undergo tearing. So the question always becomes, if you have an intact discoid and you discover it, what do you do? Do you do the desosterization procedure? Do you do nothing, wait for it to tear? And that's the clinical dilemma that you guys will all face. And I think that typically, you'll counsel the parents and say, say if it becomes painful or you have more symptoms, then we really need to kind of refer you to surgery. If you are having the symptoms, then there are surgeries to basically desosterize a meniscus, make it more like a C shape instead of a disc. And that is something that can be done. So if it presents as a tear, then you have the tear to deal with. But if you get a report back, there's a discoid meniscus, and you want to counsel about risk of tearing. There's different flavors of discoid. They're not always really large. Sometimes you'll get a report, there's a little bit of a discoid. There's not a strict definition for discoid in peds, unfortunately. We really shouldn't go past the midpoint of the condyle. We had a paper in our group which tried to look at the ratio of the discoid to the plateau. And if it was more than 50%, then that would show that they had a higher risk of tearing and need for surgery within 2 years. If there's locking and mechanical symptoms, that's also a risk factor. So it's just something that you will face, and it's almost always far and away the lateral meniscus. So that is discoid meniscus. Trauma for 500, you got it. So again, it's always hard to show an MRI case with just a still image, but I will tell you that this is a patient who had a severe knee injury. There's a big joint effusion that you can see, and I'm scrolling right through the intercondylar notch, and there's something that really shouldn't be there. The patient has really bad mechanical symptoms. There's something that is in the notch that came from somewhere else. And you want to think about what kind of tissue signal that is. What could that be? It could be, I guess, a couple of things, but if you see something in the notch that it does not look like your typical ACL or PCL, you want to think of this condition, and something may have torn and flipped into it. What I'm showing you here is not bone. I'm showing you this very dark soft tissue that tibial eminence is a very good thought, actually. You're thinking ACL full plate avulsion. Usually for those, you'll see like one little piece of bone, and it'll still look like bone, and we'll just be over here, and you'll see the ACL attached to it. Yes, bucket handle meniscal tear. So I know it's kind of a weird way to show it, but just kind of making you guys think, if you see tissue in the notch, think bucket handle tear. So meniscus flipped into the notch, and this is a bucket handle type tear. So excellent. Next, I know we're getting close to time, but I want to give you guys as many cases as possible here. Okay, trauma performer. This one is kind of bizarre, random, but this patient is a baseball pitcher, and they just had this nagging pain, posterior shoulder. You do an X-ray, you see some weird calcification. You do a CT, you see this like curled up thing, some calcification, the posterior glenoid here. Just in general, what is this a sign of? Like, what could this mean? Like, why is there calcification along this posterior part of the joint? It has an eponym, that's why it's this 400 level case. But what does this signify? Like, what can we explain? Like, why does the body lay down calcification? And it's telling you that something was injured, right? The body produces calcifications in areas to try to uh, tell us that it's trying to heal something. So it's kind of obscure, but basically this is known as a Bennett lesion. Basically, it's a eponym to show that there's injury to the capsule, the labral ligamentous capsule, and sometimes you're just going to see calcifications, and you want to be able to realize that, okay, the body put down calcification as a sign that there probably was an injury there. He's a pitcher, maybe had a posterior labral tear, some stripping of the periosteum, and that's just a sign that something happened before. Click on this here. Aha, excellent. You got the daily double. This is a great one. All right. So this is hard, but I'm really glad we have this case that you guys found it. This patient came in with thigh pain. The hint is they had a soccer injury 4 weeks prior, and the problem is that we jumped the gun, we got an MR, and we see something that's concerning now. Now we see a rounded area, a lot of edema, but it's enhancing. And radiologist policy says, I'm kind of worried about this. Could this be a malignancy? And we're seeing a solid enhancing mass. But you're thinking, gosh, that's weird. Like they had an injury. What else could this be? You guys are all over this. You guys are too smart. What would you do though to prove? Because right now this looks very scary. So what would you order? What would you do? You say, okay, you don't want to totally blow it off to prove that it is myositis ossificans. What could you do? Well, an ultrasound could be confusing as well, but let's say you do an X-ray or a CAT scan, okay? So in this case, they got a CAT scan 4 weeks later, and we're seeing rim calcification, right? So this is the zonal phenomenon of myositis ossificans in the early phases, and you can do this with X-ray or with CT. You would see this rim of calcification, and that will help you clinch the diagnosis of myositis ossificans. I think of this as sort of lava versus rock. When you image myositis ossificans, you're imaging the lava. It can look very scary, can look like a tumor, and it can be very confusing to everyone. And so you want to really think, could this be myositis ossificans? And if there's any thought about it, do a short-term follow-up film or CT, and you will help clinch the diagnosis. Now, I don't want to go over terribly, so just let me know if what we should do, but we do have a couple left. So I'll leave it up to the moderators to let me know what we should do. But you guys have done amazing, and I am impressed. Hopefully you are enjoying this here. Yeah, so what we can do is let's just finish them off and get you guys out of here. So this is a patient who came to your clinic and they have just vague pain in the hips, pain in the back. You're trying to figure it out. You're not sure. Let's get an MRI. I'm showing you a T1 sequence, and I'm showing you a STIR sequence, which is just a T2 with fat suppression. It's a hard one because we like to use symmetry. We like to try to see anything asymmetrical. What's going on with this bone marrow? Now, remember the other case I told you with the 5-month-old? This is a 5-year-old. So let's look at the bone marrow on T1. What should bone marrow look like on T1? What signal, right? And you have the fatty signal in the sub-Q. Right, it should be high signal, right? What's wrong with this marrow signal here on T1? Very dark, exactly. Very low signal. And one rule in radiology is the bone marrow should not be darker than adjacent skeletal muscle. If you ever see bone marrow darker than adjacent skeletal muscle on a T1, that's kind of a concerning feature. If you also see bone marrow that's dark on the epiphysis, epiphysis should surely be fatty by now, right? What's with this T2 image, right? We've done all the fat suppression. What about this T2 signal that's kind of off? Right? It's basically diffusely hyperintense, right? It's the bone marrow is way too bright on T2. So what do we need to think about in a patient with bone pain? And I have seen this a number of times present like this. Seen it present to ortho, sports medicine, seen it present to rheumatology, seen it present to ED. And sometimes a radiologist will give you a phone call and say, this marrow looks kind of funny. What am I worried about here? What is when you hear me saying diffuse marrow signal abnormality? What do you have to think about? Yes, ALL, leukemia, 100%. So this was acute leukemia presenting with bone pain, diagnosed by yours truly here many years ago. And so you do want to think about that. If you get a phone call, there's some weird bone marrow signal. Remember that you're going to get presented. There's going to be patients that present with that. So always remember that in young children. All right, let's go on. Let's see what this is here. This patient came in with a mass on the elbow, and you're kind of trying to piece it together. Is it a ganglion cyst? Is it what's going on? On exam, though, it's kind of hard. And you're not really sure if this fits with a vascular malformation. When we get the MRI. T2, it's bright, but not as bright as that venous malformation. You give post contrast, and you're seeing really kind of solid enhancement. Now, as opposed to the myositis ossificans case, this one doesn't really have much signal around it. And on exam, it's kind of this hard mass. What do you have to think about? What do you need to exclude in this case here? And you guys are going to be feeling a lot of masses, and you need to distinguish between just a ganglion cyst, lipoma, Baker cyst. But when you feel a hard mass and you have a solidly enhancing thing on MRI that's hypervascular, you do need to think about malignancy. And in peds, rhabdomyosarcoma, excellent, is the soft tissue sarcoma that we see. And so if we see an extremity lesion, if you feel an extremity lesion, think about rhabdomyosarcoma. Okay. Ped Puri 300. This is a 2-year-old with a limp. We don't know what happened. We get an MR. We see a ton of enhancement. We see a lesion. However, it's rim enhancing. It's in the metaphysis. And I told you that in the metaphysis, we always want to think about a particular thing, right? That loves to go to the metaphysis. And there's a ton of edema around this. So what tests do you want to know? What else do you want to know? What could this be? You have a rim enhancing thing. I tell you that this is probably fluid containing. I'll give you that. And what do you have to worry about? CBC, white count is very elevated. Fever, CRP, ESR, all elevated. Everything's elevated. And they are bacteremic. It's infectious. I'm trying to give you the hint that this is an infectious thing. Osteosarcoma, yes, you do if you see a lesion in the metaphysis, but I give you the history of infection. Exactly. Call ID immediately. Love it. Perfect. Okay. Bone marrow 300. Hint, my bone marrow always looked like this. So now remember that we said bone marrow should not be super dark. So a little bit dark, but it's not affecting the entire of the bone marrow. We're still seeing preserved fatty marrow in the epiphysis. So we're not really that concerned for a leukemic process. but a little bit too bright on T2 as well. But what's interesting is that the areas that are kind of prominent are areas where we typically will see red marrow. So it's almost like you have too much red marrow. And this patient has a chronic condition. Just wanted to just remind you of what this condition looks like. This patient may present with crises and have things like that. So what am I trying to get at here? Sickle cell, exactly. So this is just sickle cell and showing you this is the red marrow reconversion, a little bit more prominent red marrow than you typically will see. Ped-Peri. This is kind of random. I'll just show you this. This is again, lifting of the periosteum. So a subperiosteal collection. But there's something very funny about this subperiosteal collection. In the collection, there's a fluid level, which has bright signal on T1 that sats out on the fat set. So it has a fat fluid level in the subperiosteal collection. So fat fluid level is a rare thing you can see. You can see a fat fluid level in osteomyelitis, which is what this case was. But you guys may have already encountered this, or you may in your career. What happens is if you have a bad fracture, you can actually have the lipoblasts will burst and they'll leak into the surrounding tissues. So sometimes they'll be doing a follow-up for like a buccal fracture of the radius, and you'll see a new lucent lesion. You're kind of like, well, why is that there? Wasn't there 2 weeks ago? It's literally just a fat globule. So you can have these post-traumatic fat globules that can occur. This happened to be an infection case, but remember that if you have a trauma, you can have the bone marrow, just like you can have lipohemarthrosis. You can just get like a little globule. Think about when you're making the chicken noodle soup, the little fat globules will kind of float to the top. That's what you can get sometimes on MRI as well. Bone marrow. Okay, this one is not a PEDS case, but just showing you patient had fatty marrow, and then all of a sudden 2 months later has dark marrow. You get a phone call, I'm concerned for leukemia. But you say, wait a minute, weren't they just on treatment and now they're on GM-CSF and this is actually not new leukemia? What is this? This is just red marrow reconversion. So the bone marrow is very an agile organ. It can ramp up, ramp down. So just remember that when you get a phone call, you got to help the radiologist give them the history of what's going on with the patient. How about this patient? Funny marrow, weird extra stuff in the marrow. Erlenmeyer-Flask deformity. Erlenmeyer-Flask deformity. So the bones are funny in shape. You call your genetics colleague and say, wait a minute, I've heard of this. What is filling the marrow? There's a diagnosis the patient has. Starts with a G. This is Gaucher's. Gaucher's. Before we get to that. Soft tissue lesions. This is a patient with an abdominal wall mass. You feel an abdominal wall mass, you don't know what it is. It's not a hernia. You get an MR and all these very dark signal things, this mass in the abdominal wall. Radiologist says, I think this could be something fibrous. You say, wait a minute, abdominal wall mass. I also have a history of colon polyps. This is not a hernia. There's something's connecting these two. It's a syndrome, a polyposis syndrome. So remember, if you feel an abdominal wall mass and someone thinks fibrous, you want to think about a desmoid tumor, desmoid fibromatosis. You guys are going to see fibromatosis sometimes. This is a desmoid tumor, which is aggressive fibromatosis, and this was Gardner's syndrome. Let's see here, bone lesion. Okay, you are examining this baby, and you are trying to figure out. Parents come in and say baby was actually really early walker, was walking at 7 months, or maybe not walking, okay, but was crawling at 7 months and very concerned. All of a sudden, baby's not walking anymore. You do your exam, something's really funny. You get an MR, you're not really sure what's going on. Is this something, is there an injury? Report, you look at the T1, very, very low signal, very high signal on T2, some rounded masses extending into the spinal canal and kind of in the abdomen. What do you have to worry about in a 9-month-old all of a sudden is losing their ability to walk. What is going on? What is the main pediatric kind of solid organ malignancy that you need to know about for pediatrics? What do you need to know about in the baby? There's an entity that, of course, you know, and it can spread into the spinal canal. Neuroblastoma, excellent. So this is neuroblastoma. Just reminding you guys to think of these non-sports medicine things. And I think we are on to the final Jeopardy. We're almost there. This is nothing to do with sports medicine. I apologize, but I will try to make it sports medicine related. This patient came to you with a back mass. They are tumbling and gymnastics, and they've had a mass before, but they're noticing it more now. You feel the mass, and you notice also there's multiple axillary freckles, and you kind of dig into the chart and you realize, wait a minute, there's something the patient has a history of, and this is a coronal image of the back, and you're seeing multiple lesions with little target appearance. And you say, wait a minute, there's multiple of these all over the body. This is no tumbling that I've seen. Excellent. Neurofibromatosis. You guys nailed it. You guys are awesome. This was too easy for you. Hopefully, this was very helpful, well-rounded talk, kind of giving you some pearls on just how to look at MRI, look at imaging, how to remember things that aren't sports medicine related, and just when to call your radiologist for help. And so that is all. And I can open it up for any questions. Anything related to sports imaging, related to musculoskeletal imaging. I do ultrasound, I do MRI, I do CAT scan, I do adult medicine. So anything, if you guys wanted to ask a question. If not, my email can be distributed. And yeah, if you guys are ever in the Chicago area, come shout out to Lurie Children's.
Thank you, Dr. Samet. That was fantastic.
Awesome, awesome. You're very welcome. That was fun. Would have been better with the sound. I apologize.
There was the example you gave with the fatty marrow radiation changes. How soon after radiation could you expect those to change?
Good question. Good question. I think it takes a bit of time. Um, whenever we see it, it's usually like months later and it's like a known thing. Um, if you imaged it like the next day, I'm sure it would not look like that. It probably takes a little bit of time to kill the marrow. Basically, the reason it becomes fatty is you're basically killing all the hematopoietic marrow, so the only thing left is fat. So, um, but it's just something that whenever I get a weird marrow case, I always want to look in the history and make sure, like, okay, was there radiation? Was there not? What was the treatment? And yeah, it can be very tricky.
And that would just persist.
Yeah, so it can rebound. Marrow can definitely rebound. I think it's more likely to rebound when it's like chemotherapy and you give them like bone marrow stimulation medicines. If it's radiation, it's a little bit more kind of permanent. But I'm sure that the younger you are, the more time it has to kind of come back a bit. And when it comes back, it's not going to come back in the normal distribution. So that's when we get really weird bone marrow patterns. We'll get lesions because we'll get like little globules of red marrow that will like appear as the bone marrow is like trying to, return, but the scaffolding has been kind of wiped out. So it's very tricky. But I think realizing that if you get a phone call about a possible acute leukemia or diffuse marrow, take it seriously, do workup because we've seen cases over the years where, it's just very difficult. If radiologists want to, say something, say there could be cancer when you're coming in for an ankle sprain, but we do see it, and there's definitely a place to work it up. And you guys, I'm sure, see tons of things that aren't sports medicine, and you're kind of thinking, okay, well, this is not sports related. Who do I send this to? And I think it's good. Reach out to your get a radiologist friend. I get phone calls all the time from sports medicine people. Hey, could this be anything else? Is this, we see osteomas. I didn't showcase that in the talk. That's another like common thing you guys will see. You'll see first presentation of arthritis. You'll see, lots of things. I just had a case today of a like a 2-year-old with ankle swelling from sports med, and it was looking for a possible vascular malformation or mass, but the swelling was tenosynovitis. So it was just severe tenosynovitis as likely the presentation of an inflammatory arthropathy, but it was just chronic mass-like swelling. So you kind of have to like you think about a lot of other things. Keep your internal medicine or peds or family medicine or wherever you got your initial training. Keep keep that alive, because it still will be relevant for you as you practice sports med.
Yeah, thank you. Like that was great. Sports, non-sports, everything that we could see in our clinic. So that was great.
Totally, totally, totally. Yeah, and if anyone has any other questions, feel free to share my email, and we can talk some more.
Thanks, everybody.
Thank you all. Have a great night.